Please welcome your host, Molly Linson, to begin.
Thank you, and hello everyone, and thank you for attending today's Enhancing Oncology Models Start Office Hour. We will be sharing the link for today's slides in the chat. The slides include additional resources and links to access related to today's webinar and the model. For today's agenda, we will review important dates and EOM updates. We will then discuss care transformation as it relates to the model, including participant redesign activities, health-related social needs, electronic patient-reported outcomes, and EOM health equity strategy. We will then review relevant resources and information to help you all be successful in the model, and we'll close out with an opportunity for you all to ask questions to the EOM model team and engage with peers through a Q&A session. We will address questions we received from the webinar registration and as well as during today's webinar. To ask questions, please use the question function in the Zoom platform. Additionally, for questions specific to your organization, please email them to the EOM team at eom@cms.hhs.gov. Next slide, please. We're going to start by reviewing some upcoming activities and model updates. Next slide, great. So what we have coming up over the next couple of months, on July 26th, we've got the Health Equity webinar. In August, on the 9th, the Care Transformation webinar. On August 16th, we have the Learning System What's Ahead webinar. Moving into September, on September 13th, the PRA Attestation and Health Equity Plan office hours. And on the 29th, it's the deadline to implement all PRAs, the PRA Attestation and Optional 2023 Health Equity Plan. And then on October 11th, we will host the Feedback Reports and Dashboards webinar. Like I mentioned, if you have any specific questions, feel free to reach out to the EOM team. With that, I will pass it to Eileen to review EOM participant sites of care. And with that, Eileen.
Thanks, Molly. So we are very excited to announce that we have 44 physician group practice participants representing 561 sites of care and over 2,800 practitioners in 34 states. So we're so glad you are here with us, showing your commitment to continue improving support for your patients and enhancing their care experience, which aligns with one of the key goals of President Biden's Cancer Moonshot Initiative. We're looking forward to working with you closely in this important initiative and helping you to be successful with the model's implementation. Can we go to the next slide, please? So we are also excited to announce we have 3 payers who will be participating in EOM. They are Blue Cross Blue Shield of South Carolina, Blue Cross Blue Shield of Tennessee, and CVS Health Aetna. These payers will align with EOM in key areas, including their payment approach, commitment to health equity, and data sharing with EOM participants and CMS. We will allow additional payers to join EOM throughout model implementation as long as they are partnered with at least one EOM PGP participant and sign a memorandum of understanding. If we could go to the next slide, I'll turn it over to Batsheva.
Great, thanks, Eileen. Here you'll see an overview of the EOM reporting requirements. The first Participant Transformation Plan, PTP, was due this past Friday. Thank you for completing the survey at this time. Responses will help us better understand current practices related to care transformation and will be used to inform learning activities and resources to model participants. The PTP survey is an opportunity for participants to share their growth and experiences with care transformation throughout the model. As noted above, participants will be asked to submit this survey semi-annually. The next upcoming submission is the PRA attestation, and that is annual. Attestation is in regards to implementation of the PRAs. This will be shared in a number of weeks with EOM participants. The first due date is coming up in September 29th. The next item here is the participant reported quality measures, and that is also annual. There's no reporting, however, until early 2025. So participants would submit data to CMS between January to mid-February for the previous year's data. So for January to mid-February 2025 for calendar year 2024 data. Next item is the CDEs and the SDEs, so the clinical data elements and the socio-demographic data elements. That submission is semi-annual. After participants receive their attribution data, approximately 4 to 5 months after the end of the performance period, participants will have 30 days from when they receive that data to submit CDEs and SDEs to CMS. Just a note, the SDE guide had a minor update and is now refreshed on the CMS or the EOM website as well as Connect. And that update was written in regards to the preferred language appendix. So please be sure to take a look at that and use the latest guide there. The next is the Health Equity Plan, and that is annual, and the guide is available on the website, and the guide template and additional resources are all available on Connect as well. In our next webinar in July, we'll go through these resources in more detail and walk through, and that the first Health Equity Plan is optional for submission, and that should participants choose to report, will be September 29th, and then March annually. So I will turn it back to you, Eileen. So next slide, please.
Thanks, Bachwa. So this is an outline of forthcoming data, just to give everybody a heads up. So the first piece of data we plan to share will be the monthly claims data for the wider population of beneficiaries that could potentially be attributed to your practice. We plan to share this in a few months in September. Next, we are planning to share the initial EOM dashboards in early fall. Again, this will be for a wider beneficiary population of those beneficiaries who could potentially be attributed to your practice. The dashboard will include beneficiary characteristics and utilization, expenditure information, and end-of-life metrics. The initial dashboard will cover a period before model start. Then the dashboards will be updated with similar information to this initial dashboard for the first quarter of EOM in December of 2023. This will allow participants to start seeing patterns and trends across their metrics, which we will continue to update throughout the life of the model. We will also be providing monthly updates to the novel therapies list. I did want to acknowledge the fulvestrant issue that was flagged, where fulvestrant was excluded from the initiating therapies list for performance period 1, but was included on the initiating therapies list during the baseline period. We are actively working on a solution and will provide updates to participants as soon as possible. If we could go to the next slide, and I will pass it back over to Bachwa.
Thanks, Eileen. And now we'll go over an overview of the care transformation strategy. So next slide, please. So this slide presents an overview of the participant redesign activities, or PRAs, in EOM. The first 6 PRAs are enhanced services for which EOM participants can bill MEOS, the monthly enhanced oncology services payment, for furnishing these enhanced services to EOM beneficiaries. PRAs include providing 24/7 access to appropriate care, patient navigation, documented care plan in alignment with the 13 required components of the IOM care plan, treatment of beneficiaries consistent with nationally recognized clinical guidelines, identifying health-related social needs using a health-related social needs screening tool, gradual implementation of EPROS, use of data for continuous quality improvement, and use of certified EHR technology. We'll be taking a deeper dive during the Care Transformation webinar August 9th over all these elements as well. For additional information on the PRAs, including the core elements of patient navigation and a list of the 13 elements of the IOM care plan, please see Appendix B of the PA. Next slide, please. I just wanted to flag here that the PRA attestation will be available soon, and the participant portal to view and the submission date, as I mentioned in the previous slide, is September 29th, to put on your calendar. The participant redesign activities listed in the previous slide must be offered by EOM participants to EOM eligible beneficiaries. All PRAs must be implemented within 90 days from the participant start date, except for the use of certified EHR technology, which is required to be implemented at the start of the model, and EPROS, which will be gradually implemented and phased in during the course of the model. Participants are required to maintain documentation of PRA implementation and provide access to documentation upon CMS's request. For example, we may ask for documentation as part of monitoring during site visits or EHR reviews. EOM participants will be asked to certify the implementation of PRAs annually via the PRA attestation, and this will be due around 90 days after the participant start date and annually thereafter. Next slide, please. So now we'll take a moment to review the HRSN and EPROS requirements again. I know there's a number of details here, and so we thought it'd be helpful to go over once more. This can both been found in the HRSN guide and the EPROS guide, which are available on the website and Connect as well. So at a high level, with non-clinical drivers of health being one of the largest contributors to health outcomes, it's very important to use HRSN screening tools to inform care. HRSNs are adverse social conditions that negatively impact a person's health or healthcare and are associated with increased healthcare costs and utilization. HRSN screening can help capture these individual level factors and aid in care planning and patient navigation, which are also PRAs in EOM. For these reasons and more, EOM participants are required to screen for EOM beneficiaries' health-related social needs using a health-related social needs screening tool for the following domains: food insecurity, housing instability, and transportation. Participants are encouraged to screen for additional domains, including but not limited to social isolation, emotional distress, interpersonal safety, and financial toxicity, as meets the needs of your unique beneficiary population. While we currently do not require the use of a specific tool, we encourage participants to use free and non-proprietary tools. We've included a few examples of HRSN guides and tools here and in the guide as well. For additional information, please see the Health Equity Strategy fact sheet as well as the HRSN screening guide on the model website and Connect. Next slide, please. Beginning at the start of the model, participants have 90 days to implement the PRAs, including HRSN screening. As part of this process, if you have not done so already, you will want to identify your HRSN screening tool or tools and begin to collect HRSN information from your beneficiaries. EOM participants are able to select the HRSN screening tool that you would like to use. We have included examples here of free and non-proprietary tools that EOM participants are encouraged to use. HRSN data can assist in decision-making to help improve patient experience and facilitate whole person, patient-centered care. HRSN data can also be leveraged for care planning and to connect patients with referrals and community resources, as well as to help identify areas of need and create community linkages. Once a need is identified, participants can facilitate patient navigation where applicable. This includes but is not limited to those referrals to community resources for those identified needs. While EOM participants are not required to report beneficiary level data to CMS at this time, we may request the EOM participant to share, for example, which HRSN questions and or tools you are using. Next slide, please. And now I'll turn it to Allison to go over the EPROS.
Great, thank you, Bacheva. So to start with a quick review, what is a PRO, or a patient-reported outcome? As we previously discussed, a PRO is a measurement based on a report coming directly from the patient. EPROs are outcomes that are electronically captured. Both the EPRO guide as well as the EPRO fact sheet are linked here on the slide. The CMS has outlined defined domains and standards for use of EPRO technology in the model, and that's really to ensure the use of high quality surveys and to help meet the model goal of improving care quality. EOM participants are required to use EPRO surveys to capture, where applicable, beneficiary level outcomes for each of the following domains at a minimum: symptoms or symptomatic toxicities, and we've included examples of symptoms that are common across cancer types; functioning, which is meant to include physical functioning as well as role functioning, which as an example includes collecting IADLs and or ADLs; behavioral health; and health-related social needs. In addition to the required domains, EOM participants will be asked to review responses with their beneficiaries and integrate EPRO data into their EHR. Next slide, please. While we do not require a specific tool to be used for collection, EOM participants are encouraged to use non-proprietary EPRO tools and communication methods that are valid and reliable across diverse populations. So this slide provides reference to many well-established and tested sources. So first, we've listed programs focused on capturing symptoms, and those include the PROS CTCAE, PROMIS, ESAS, etc. In addition, we have provided references to EPRO tools which address physical function or frailty, and those include ECOG, the geriatric assessment, and the PROMIS Global 6. Slide, please.
So EPRO implementation is gradual, providing participants time in those first 2 years to identify tools and data collection methods and implement the capabilities necessary to collect EPRO data. That being said, implementation of EPROs is not required until model year 3. We understand that participants may be at different phases of using EPRO tools and that there may be some participants who are currently collecting EPRO data. We also understand there are others who plan to use model years 1 and 2 to pilot or test approaches within their practice. So this graphic on the screen provides examples of how participants may increase the EPRO administration percentage in years 3 through 5. And we want to emphasize that these are example percentages. EOM participants will be asked to obtain response data from an increasing percentage of eligible beneficiaries over the course of the model. CMS will provide more detailed information later in the model, and we also welcome feedback from participants. EOM participants are not required to transmit EPRO data to CMS at this time. However, as the EPRO field progresses and CMS assesses the implementation of EPROs under EOM, CMS may require that EOM participants report EPRO data beginning in later performance periods. CMS will also continue to update the EPRO guide as well based on feedback. Next slide, please. We'll pass it back to Bashaba.
Great, thanks, Allison. And I'll take a minute to go over the EOM health equity strategy broadly. And as I mentioned, we'll have a whole webinar dedicated to health equity as well as health equity plans coming up soon. So just to refresh, CMS defines health equity as the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health, regardless of race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, preferred language, or other factors that affect access to care and health outcomes. EOM seeks to improve quality of care and equitable health outcomes for all EOM beneficiaries, including, but not limited to, incentivizing care for underserved communities, such as the inclusion of our differential meals payment, so having the base $70 per beneficiary per month payment with the additional $30 per beneficiary per month payment for dual eligible beneficiaries, and that additional $30 is outside of the total cost of care responsibilities. We factored in dual status and low-income subsidy status as part of the total cost of care benchmark. In terms of collecting beneficiary level sociodemographic data, EOM participants are asked to collect and report that data to CMS for purposes of monitoring and evaluation semi-annually. And as we discussed earlier, more information can be found in the SDE guide. And next, we have identifying and addressing HRSNs. EOM participants will be asked to screen beneficiaries using screening tools for a minimum of 3 domains: the transportation, food insecurity, and housing instability. And that frequency is a minimum of once per performance period for that specific requirement. There's some other specific requirements for the HRSN domain under EPROS, and more information on that can be found in the EPROS guide. Next is the improved shared decision-making and care planning. EOM participants will be required to develop a care plan with the patient, including discussion of prognosis and treatment goals, a plan for addressing psychosocial health needs, and estimated out-of-pocket costs. And last but not least, developing health equity plans as part of data for continuous quality improvement. EOM participants will be asked to develop a health equity plan as part of using data for CQI. There are a number of resources, as I mentioned, on Connect, as well as the model website, and we look forward to reviewing that in more detail on the webinar on 7/26. Next slide, please. And I will turn it to you, Molly.
Thank you. So really quickly, wanted to pause here on this slide and provide you all with just some additional resources to help you all stay up to date on some upcoming model events. So you'll find the model website, help desk contact information, Connect site, and as well as our Twitter handle here on this page. Next slide. As a reminder, EOM Connect is a great resource for you all to network with other model participants and connect with the EOM team. All of this is really just meant to enhance your experience and participation in the model. If you have not yet signed up for EOM Connect, you can use the links on this slide to get started and learn more. And if you have any questions while gaining access or just questions in general, you can contact the EOM help desk at eom@cms.hhs.gov or by calling the number on the bottom of the slide. There are also a lot of great resources on the EOM website, so also encourage you all to check out the website for additional resources. I will now pass it to Eileen to review some of those additional resources. Can we go to the next slide, please? Thank you. Eileen?
Thanks, Molly. Thank you. So the team has been hard at work creating a wide range of resources to support your practices with implementation of the model that we wanted to highlight. So we have high-level overview resources and payment resources, which are all available on Connect. I also want to note the EOM participant portal is available, and that's where you can update and maintain contacts for your organization and also submit deliverables. I did want to mention that only contacts listed in the participant portal will receive the biweekly e-news that has a lot of useful information available. If we could go to the next slide. So continuing on from the last slide, we have numerous resources on different quality topics, including guides that Bachva had mentioned on the quality measures, clinical data elements, and health equity plan, among others. Again, these resources are all on Connect. Additionally, we have provided historical period claims data for approved EOM participant data custodians and resources on how to access that data. If you have any questions on accessing Connect or the portals, please reach out to the help desk. And if we could go to the next slide, that will have the help desk email available. We're now going to move on to our Q&A portion of the call. If you have questions, please submit via the Q&A function on the bottom of your screen. And if we don't get to your question, please be sure to submit an email to the help desk. So I am going to start with a couple of questions that came in. So there was a question saying there was a couple of errors in the placement of the fillable fields in the Spanish version of the beneficiary notification letter. Can we get an updated version of that document with a smaller font size in the fillable fields as well? So yes, thank you for flagging that. We will work on getting that updated and out to everybody. The next question was asking, does Aetna's participation include all plans across the US, or it's a partnership with certain PGPs? So yes, it's a partnership. It's the latter. It's a partnership with certain PGPs that are participating in EOM. Let me move over to another question here. Hillary, this one's for you. I was going to ask, how many current participants and payers are there in EOM? With the current number of participants, what does that mean in terms of impact of the model?
Yeah, absolutely. So as we shared previously at the top of this office hours, we're excited that we have 44 PGP participants and 3 commercial payers. Across those 44 participants, we have over 500 sites of care that represent 34 states and 2,800 unique practitioners. And with a substantial amount of reach and representation across the United States, CMS is really encouraged about the potential impact EOM may have on improving the patient experience in their cancer treatment journey. So moreover, EOM was intentionally designed in a manner that holds participants to be accountable for quality and spending, because during model development, CMS determined that the model design was the most likely to support longer-term system transformation. So CMS is committed to value-based care, and we strongly believe that the current EOM participants will be better positioned for the future of oncology care.
Great, thanks, Hillary. Another one for you that we kind of touched on, but fulvestrant was excluded from the initiating therapies list for PP1, but included in the initiating therapies list for the baseline period. Is the EOM team aware of this difference in the initiating therapies list, and how will it be addressed?
Yeah, absolutely. So CMS and the EOM team is aware that fulvestrant was excluded from the initiating therapies list for performance period 1, but included in the initiating therapies list for the baseline period. And while fulvestrant is a hormonal therapy, it is typically used for high intensity breast cancer by way of injections, as opposed to some oral hormonal therapies. So we understand the importance of accurate alignment between the baseline period and the performance period for this particular drug and for the purposes of benchmarking. We are working on a solution as quickly as possible that we hope to share with you all as soon as we can. And we just thank you for your patience, but know that we are working through that issue actively.
Thanks, Hillary. Batsheva, I'm going to ask this one to you. How are practices managing sharing out-of-pocket costs for beneficiaries as one of the elements of the IOM care plan requirements? Are there tools available to help estimate and share out-of-pocket costs?
Yeah, thanks, Eileen. Just at a high level, CMS sees the care plan based on the 13 elements of the IOM care management plan, including the out-of-pocket cost estimation as a living document, really, that needs to be kept up to date over time as information is available and based on cost estimates and as that information becomes available over time. The out-of-pocket cost estimate should reflect a minimum of 6 months, so that's the length of the episode, but can be longer to reflect the time frame of the treatment plan if the practice chooses. It's important that the practice be clear in its discussions with the patient, indicating what time period is being reflected in the estimate. The out-of-pocket cost estimate should reflect the cost of cancer care, so even after chemotherapy has ended, there may be additional costs for the patient related to follow-up labs and tests, which should be included in the estimate. The goal of estimating out-of-pocket costs is to help patients understand the potential financial impact of their cancer care and reduce a beneficiary's associated financial toxicity. We expect participating practices to engage in conversations with patients about their costs of care and provide an estimate of these expected costs as they relate to the patient's cancer care. Estimates can include a range of costs depending on possible courses of treatment, and they can evolve over the course of the patient's care. At a high level, practices may provide an estimate of the magnitude of costs. For example, you can expect $10,000 of out-of-pocket expenses over the next 6 months. Though we expect practices to build over time the capabilities to present more precise and comprehensive information. Through the EOM learning community, we'll facilitate sharing of best practices among participants, and we welcome participants to share current practices as well, including payers, on how to estimate this information and provide it to their patients. Back to you, Eileen.
Thanks, Batsheva. Liz, I've got one up for you next. Will the count of costly conditions and comorbidities included in the price prediction model for the beneficiary be from those captured, coded during the performance period episode dates during that calendar year or captured in the calendar year prior to the episode?
Yeah, that's a great question. So the primary comorbidities and the costly conditions are those captured in the calendar year prior to the episode. Those are nearly always going to be the most recent data available to us when we begin reconciliation. So those are the data that we use to ensure that we have the comorbidity data for all episodes at the time of reconciliation.
Great, thanks. Batsheva, this one's for you. Does the electronic portion of EPROS refer to the capture of PROS or to the filing or both? So for example, is it more about getting patients to complete them using an electronic device or method, or is it more about ensuring these results are captured in an electronic system?
Thanks, Eileen. As Allison mentioned, EPROS is the electronic capture of PROS, and this is really to emphasize integration with EHRs, as well as the ability to integrate this data as part of a participant's workflow. The goal is to make this a seamless experience and ultimately part of the culture of care, so that there is increased communication and improved communication between the provider and the beneficiary. And so having that electronic capture really facilitating some of that processes. Just to note, we have mentioned previously that the capturing of this information can be done in a number of formats. So the participant can choose to collect this information anytime before the visit. So it could be up until the office visit. Obviously, we would like to see more collection of this eventually evolve to EPROS collection well in advance to capture potential concerns before they become, for example, acute care utilization. But as this develops, it could be seen as screen-based reporting devices, so the patient portal or on a smartphone, or it can be an interactive voice response system, so calls to the patient who responds to phone prompts. It could be text systems, So the patient provides information via their text or even in the waiting room, as I mentioned, in a tablet. There might be a number of different formats in which this can take, and we would really welcome hearing more from participants. If you have other ways in which you're engaging with EPROS, that we can include this information in the EPROS guide to be of assistance as well. So back to you, Eileen.
Great, thanks, Batya. Allison, I've got you up next. How does CMMI determine which drugs make it onto the novel therapies list? And how will CMMI determine which drugs are being used for which indication in order to apply the novel therapies adjustment?
Yeah, great question. The novel therapy adjustment will be applied to oncology drugs that receive FDA approval for either a new drug or a new indication, and that's after June 30th, 2021. Those drugs will be eligible for that NTA for 2 years. However, the novel therapy designation may extend for several months beyond that 2-year period in order to, align with the EOM reconciliation process. Several clinicians review the list, and we also often consult with the FDA.
Great, thanks, Allison. Batya, I know we've gotten this question a couple times. What if my PGP cannot implement all PRAs within 90 days of the start of the model?
Yeah, thanks for that question, Eileen. For participants to be compliant with model requirements, the required participant redesign activities must be implemented within the 90 days of the EOM participant start date, with the exception of use of certified EHR technology, so CERT, which is required for the start of participation, and EPROS, which has that gradual implementation timeline to be starting collection starting in model year 3. That being said, we imagine this will be an iterative process in how PRAs are furnished to EOM beneficiaries throughout the life of the model. CMS plans to distribute the PRA attestation, which will contain the certification required by the agreement around the time, so in the next few weeks, as I mentioned. And then the completed participant redesign attestation will be due approximately 90 days, so the September 29th, and then annually thereafter. So failure to implement the required participant redesign activities could result in remedial action, and more of that information is detailed in the PA. But just noting it's important to furnish the enhanced services, particularly as in the relevant performance period, since they're related to eligibility for billing of MEOS as well. So just wanted to flag that there.
Thanks, Batya. And then we got a question asking, how often does the depression screening need to be done?
So the depression screening as part of the EPROS versus depression screening as part of the quality measure, we can note that. I will say we do have a quality measure that is preventative care and screening for depression and follow-up plan. So if for that particular instance, we are following closely with the MIPS specifications, and as notes in the MIPS, it's a minimum of once per measurement period for a patient seen during the measurement period. So that's kind of in terms of the measure itself. In terms of collecting information on behavioral health as part of EPROS, if that is what the question is specifically targeting, I think the minimum of once per performance period is what clinically, we have to, obviously, we defer to clinical, what clinically makes sense for the patient. But overall, we have some guidance in the EPROS document that lists out a little bit of the nuances between the HRSN screening and the EPROS screening. So for EOM participants, that have that HRSN domain in the EPROS, that's also a component there. But EPROS have to be completed at least once before each E&M visit, with the exception of the first visit. So it could just be a check-in just to see if the patient has had any change in status, or it could have more of a fleshed out, but just wanted to note there is a difference between the requirements for the measure versus EPROS collection. And if there's any further questions there, we're happy to answer them offline if I didn't capture the exact response that the participant had. So thanks, Eileen.
Thanks, Batya. Okay, there was a question that we've gotten before. How do we receive the additional $30 for MEOS payments for dual eligible beneficiaries? There's only one billing code listed in the MEOS guidance document. Is there a second code we need to bill? So EOM participants only need to bill the MEOS billing code with the billed amount of $70. There's nothing a participant needs to do when billing MEOS differently for a dual or non-dual beneficiary. This will be determined when processing the claims, and payment will be made accordingly. So if a beneficiary is determined to be dually eligible, the participant will receive a total payment of $100. Just give me 1 second. I'm going to check here on some more questions. Okay, we did get a question asking, so you touched on the out-of-pocket costs, but are there tools you recommend, or will there be a tool like OCM had for practices to use? So we do have the learning system looking into this request, and we do welcome participant feedback. We had gotten mixed results in OCM, but you know, we are open to hearing feedback from participants about the out-of-pocket cost calculator. Let's see here. There's a question asking, could you please share the slide regarding the dates for various reporting that will be provided with the approximate dates? I'm wondering if you're talking about this particular slide deck or a previous slide deck, but yes, all the slides will be available in Connect. Again, if anybody has questions, please feel free to throw them into the Q&A chat at the bottom. Oh, okay, yes. So the question was asking about this particular slide deck with the reporting requirements. Yes, this will be available shortly. Okay, there was a question asking when will we be able to request the EOM HDR application in IC, and right now this is going to be approximately fall of 2024, and that's before CDE and SDE reporting is required. But you'll receive access prior to obviously the reporting being required. I'm just going to leave this open for another minute or two to see if we have any other questions that come in. And again, if you come up with a question after we close out, please contact the EOM Help Desk either by email or the phone option that's in the chat right now. Okay, I'm not seeing any other questions come in. Thank you all so much for participating and for submitting questions. I am now going to turn it back over to Molly to close us out.
Thanks, Eileen. Before we close out, I'd like to remind you of several resources available to you, including today's presentation slides shared in the chat. You can find all of today's resources as well as resources from past events in the Connect library. As a reminder, to access these files, just log into your Connect account and hit Files in the upper right-hand corner of your screen. You will then see the folders listed on the screen. Materials will be organized by topic area. To access event materials, click on the onboarding folder and then the webinar subfolder. You may also use the search bar at the top of your Connect homepage to search for specific materials and resources. I wanted to thank all of our speakers that participated today. Before we wrap up, I'd also like to note that when today's office hours ends, you will be prompted to complete a brief survey. We sincerely appreciate your feedback as we seek to improve future events. That concludes our event today. Thank you everyone for joining, and again, for all you're doing to enhance oncology care. Have a wonderful rest of your day.